So hello everyone and welcome to this conference discussion session. So I recently attended this conference, that is MRI teaching program, which was held in Bombay at the Hotel Sea Princess on the 5th, 6th and the 7th of April, and I found the sessions extremely useful. So I wanted to make a video to summarize the 3-day conference, and I have made it in a case-based format to make it more interesting and hope you like it. So I have a mixture of both long cases or OSCE cases as well as short cases or spotters. So starting with my first case, so here we have a 50-year-old male who's retro-positive and he presents with history of fever and seizures since the past 1 month now. And this is the MRI done for this patient. So these are the T1 post-contrast axial section and these are the T2 weighted images axial section of the brain. So what we can see here is there is a ring enhancing lesion, a well-defined ring enhancing lesion in the left frontal lobe, which has some perilesional edema, which is seen well on the T2 weighted images. And the lesion, the central part of the lesion is T2 hypointense, as we can see, and it has a thick wall. So considering the history of HIV, this particular lesion is likely to be a tubercular granuloma. So hence a course of ATT was started for this patient, considering the diagnosis. So this is the picture 1 month post starting of ATT or anti-tubercular treatment, where we can see that multiple ring enhancing lesions with perilesional edema are seen in bilateral cerebral and cerebellar hemispheres. So what do you think has happened post this treatment? That it has flared up, the infection has flared up, and there are so many infective granulomas that are seen in the brain parenchyma. So either we can think of an alternative diagnosis other than tuberculosis, or we can think of another condition which can cause this in a retropositive patient. So this is a case of IRIS or immune reconstitution inflammatory syndrome, which is actually a paradoxical deterioration of the pre-existing illness following abrupt improvement in the individual's immune reaction. It is classically seen in HIV patients following initiation of ART or antiretroviral therapy, and the patients at highest risk are those with low CD4 count, that is less than 50 cells per microliter, and high plasma HIV RNA prior to the initiation of therapy. Also in patients with rapid increase in CD4 count or decrease in HIV RNA following initiation of ART, and also in initiation of ART soon after the diagnosis of an opportunistic infection. So in all these conditions, the patients are at high risk of developing IRIS or immune reconstitution inflammatory syndrome, and this possibility has to be considered in any case of HIV positive patient. So I have made a video on the opportunistic infections and neoplasms that are seen in HIV patients, and the link to that video is in the description box below. So this is my next case. So here we have a patient who presented with severe headache, and this is the MRI done for this patient, and we can see an ill-defined hyperintense area on this T2 weighted images. Both on T2 and FLAIR, this area, hyperintense area, was seen in the periventricular white matter in the right occipital region. And on the post-contrast T1 weighted images, there was no significant enhancement that was seen. On perfusion imaging, we could see that there was a relative increase in the cerebral blood volume, and choline peak was seen, even though the NAA was relatively preserved. So a follow-up was advised for this patient, and on follow-up scans, as we can see that the area, hyperintense area, is increasing in size. The cerebral blood volume is also increasing, even though there is still very subtle or relatively no enhancement that is seen on the post-contrast T1 weighted images. And as the tumor progresses, this particular area progresses, it enlarges and CBV increases, there is mild subtle enhancement that is seen on the post-contrast images. So this particular phenomenon that is observed in the MR perfusion maps is called the angiogenic switch. So as the tumor progresses or increases from low grade to high grade, there is definitely increase in the cerebral blood volume that is actually depicted on the perfusion imaging. And perfusion imaging in this case was helpful to detect this particular lesion before the T1 post contrast images, and hence this particular phenomenon has come to a very good use and to detect a low-grade glioma with the help of perfusion imaging. So we should remember to do a perfusion map or perfusion imaging in any case of suspected low-grade neoplasm where the T1 post-contrast images is not very definitive for the diagnosis. So angiogenic switch that is observed in MR perfusion is a technique which is used to assess the hemodynamic parameters of the tumor. And the angiogenic switch is a process by which tumor progresses from an avascular phase to a vascular phase in their growth. And the new vessels promote growth by conveying oxygen and nutrients and removing the catabolites. So solid tumors need a blood supply to grow beyond a few millimeters in size, and tumors can cause this blood supply to form by giving off chemical signals that stimulate angiogenesis. So that is the perfusion. That is the basis of MR perfusion angiogenic switch, which was very helpful in this particular case to diagnose a low-grade glioma before it progressed. So coming to my next case, so here we have a 50-year-old male with postural headache and diplopia since the past 6 months now. So based on this set of images, what do you think the diagnosis is? So I have provided here T1 post-contrast sagittal section, axial section of bone window of this particular patient, T1 post-contrast coronal section, and also a particular sign that is seen in this particular condition. So based on all this, what is the diagnosis? So coming to the findings on this sagittal images, what we can see that there is a very prominent dural venous sinus, as we can see. Along with that, we can see that there is enlargement of the pituitary gland. On the axial section of the bone window of the CT scan, we can see that the calvaria is thickened and there is some layering that is seen within the calvarial bones. On the coronal section, we can appreciate that there is some meningeal enhancement, some pachymeningeal enhancement that is very well seen. And on this particular image, what I am trying to show is a particular sign. This is a normal dural sinus, and this is the abnormal dural sinus, which is actually distended and appears convex. So based on these findings, what is the diagnosis? So this is the cervical spine imaging MRI of this particular patient, sagittal section. What do you think is seen in this particular case? Anterior to the spinal cord, anterior epidural space, we can see CSF intensity. So based on all this, what is the diagnosis that is seen? So the diagnosis is idiopathic intracranial hypotension or spontaneous intracranial hypotension. So intracranial hypotension, also called craniospinal hypotension, is a clinical entity that results from CSF leak that almost without an exception occurs from the spine, either into the epidural space or directly into the veins in the setting of CSF venous fistula. And it usually, but not invariably, presents clinically with orthostatic headaches. So it is broadly divided into primary and secondary. Primary is usually referred to as spontaneous intracranial hypotension, and secondary is secondary to some iatrogenic cause like lumbar puncture or surgery, or over shunting due to diversion devices or any trauma. So to understand idiopathic intracranial hypotension, the imaging features of idiopathic intracranial hypotension, we first need to understand what exactly is Monro-Kelly hypothesis. So according to Monro-Kelly hypothesis, it's a pressure volume relationship that aims to keep a dynamic equilibrium among the essential non-compressible components inside a rigid compartment of the skull. So the brain tissue, the CSF and the blood are in a dynamic equilibrium. So a decrease in one of the components should be compensated by an increase in the other and vice versa. So here, as we can see, the CSF decreases in spontaneous intracranial hypotension. So as the CSF decreases, the blood has to increase, the brain tissue has to increase to compensate and to maintain the equilibrium. And because of that, we could see the enlarged pituitary gland. We could see the distension of the dural venous sinuses on imaging. The opposite happens in idiopathic intracranial hypertension. As the CSF increases, the brain tissue and the blood decrease. Now coming to the imaging features of spontaneous intracranial hypotension or primary intracranial hypotension. So why I have kept this particular case in my discussion is whenever you suspect a case of intracranial hypotension which needs a high clinical suspicion, you have to take a contrast image of the MRI. Now why is that? It's because the most common qualitative finding for diagnosis of intracranial hypotension, spontaneous intracranial hypotension, is pachymeningeal thickening and enhancement. So this is a very important qualitative finding that is actually included in the criteria for the diagnosis of intracranial hypotension. Just followed by other qualitative findings like dural venous engorgement, tonsillar herniation, subdural collection. So other than these qualitative features which help in the diagnosis, there are some quantitative features as well which can help in making the diagnosis when these are not actually present. So the qualitative features include a pachymeningeal enhancement, which is the most common finding and because of which the protocol should include a post-contrast image, even though it becomes less prevalent over time after the onset of symptoms, and hence in patients with chronic duration of symptoms in whom clinically the headache pattern also changes from orthostatic to atypical constant headache, the absence of dural enhancement may hinder the diagnosis of intracranial hypotension. In that case, we can take help of other imaging findings as well as quantitative signs to diagnose this particular condition. So increased blood volume, which is actually seen in the form of venous distension sign, which I showed in the previous slide, which was convex borders of the dural venous sinuses. It's called venous distension sign. Other than that, there is intracranial venous thrombosis as a well-recognized complication of this particular condition. There is enlargement of the pituitary gland, which was seen on the sagittal images. We can also encounter subdural effusions and subdural hematomas in this particular condition, along with reduced CSF volume, which is actually seen in the form of sagging brainstem and drooping splenium of the corpus callosum. Also, the important thing on CT that has to be remembered is a layer cake skull, which I showed on the bone window of the CT scan. The skull was layered and thickened. So some of the quantitative signs which can help in the diagnosis of intracranial hypotension are mammato-pontine distance reduced to less than 6.5 mm, pontomesencephalic angle less than 50 degrees, and an interpeduncular angle of less than 40.5 degrees. We'll see how to measure it now. So here in the protocol, we should have a high clinical suspicion first. After that, MRI brain with contrast has to be done. CT brain thin slice we can take with bone window, and then followed by MR or CT myelogram to detect the particular leak or spinal leak from the cord, and a lumbar epidural blood patch to actually correct the condition. So this is the Burn score for the diagnosis of idiopathic intracranial hypotension, which includes major as well as minor criteria. So the major criteria, which are given 2 points each, include the engorgement of the venous sinuses, pachymeningeal enhancement, and hence post-contrast images are very, very important. Supracellular cistern of less than equal to 4 mm. The minor criteria include subdural fluid collection, prepontine cistern less than equal to 5 mm, and mammato-pontine distance of less than equal to 6.5 mm. So I'll show you how to measure all this. So a patient with a score of less than equal to 2, 3 to 4 or more than equal to 5 have low, intermediate and high probability of a spinal CSF loss respectively. An MRI may reveal an extensive non-focal extradural CSF collection, as was seen in our case in the cervical spine imaging, which is iso-intense to CSF and contains the dilated epidural veins. So this Burn score is very important for the diagnosis of intracranial hypotension. So coming to the quantitative parameters to measure or diagnose idiopathic intracranial hypotension, starting with the mammato-pontine distance, that is the distance that is measured between the mammillary bodies and the superior aspect of the pons. So this distance is actually reduced in case of idiopathic intracranial hypotension. Then the pontomesencephalic angle, that is measured and it is actually drawn between these two lines. The two lines are the anterior aspect of the midbrain and the anterosuperior aspect of the pons. and between these two lines this angle is measured, and the normal angle is 55 to 75 degrees, and a reduction in this particular angle is suggestive of idiopathic intracranial hypotension. Now the third quantitative parameter is the interpeduncular angle, and interpeduncular angle is measured at the level of mammillary bodies on a T2 weighted images between the cerebral peduncles of the midbrain. So as we can see, this angle is also reduced in case of idiopathic intracranial hypotension. So coming to my next case, so here we have a 60-year-old male who presented with progressive bradykinesia, tremors at rest, rigidity and postural instability since the past 2 years, with more severe clinical manifestations on the right side as compared to left. And based on this particular SWI images, these are susceptibility weighted images, high resolution susceptibility weighted images just taken in 3 Tesla machine. This is the axial section at the level of midbrain. What do you think the diagnosis is? A particular sign is observed here in this particular case. So as by clinical features, we suspect a case of Parkinsonism, and on this particular midbrain section of the susceptibility weighted images, we can see that this is the substantia nigra, and normally the anterior part of the substantia nigra is hyperintense, while the posterior part is actually split like this into it resembles a tail of a bird, based on which the sign is named, and also like a sandwich it looks. This is a normal substantia nigra, while on the opposite side we can see that this particular tail sign posteriorly is lost. That is because of the loss of nigrosome 1. So this tail is preserved here, though it is lost here. So this is normal and this is abnormal. So this sign is called a swallow tail sign. So this is a swallow bird which has a tail like this, which resembles this particular appearance of substantia nigra posteriorly. So it is important to note that adequate visualization of the swallow tail sign requires a targeted 3D high resolution SWI images. We can't actually see it without proper 3D thin section of the midbrain, because it is very subtle, and it is seen in case of classic Parkinson's disease. So coming to a similar case of movement disorder, and this is the imaging of this particular patient. So this is a different patient who presented with similar imaging, similar clinical features, and this is the imaging on MRI. So these are the sagittal images and these are the axial images. So what are the important signs that are seen here? So it is very simple and a spotter case, as we have been reading it since our undergraduate times. So this is actually looks like a beak of a bird. This entire thing looks like a bird, and this looks like a beak of the bird. So this is actually midbrain, which is very thinned out, and the pons is preserved, the medulla is preserved. The midbrain is actually thinned down, and the axial section taken through this particular area shows a deepened interpeduncular fossa and convexities along the lateral borders of the midbrain. So this is the hummingbird sign that is seen on the sagittal images, and on the axial images it is called the morning glory sign. That is because of the convexity of the lateral margins of the midbrain. Also, it appears like a Mickey Mouse. It is also given the name of a Mickey Mouse appearance. So it is seen in case of progressive supranuclear palsy, which is actually a Parkinsonism plus syndrome. So a very important thing that has to be mentioned in a report of a case of suspected PSP or progressive supranuclear palsy is MR Parkinsonism index. So till now we have learnt typical signs that are seen in PSP, but if those signs are not typically seen, then this particular measurement has to be done and given in the report. So how is it measured? So it is measured by calculating the width of the superior cerebellar peduncles in the coronal plane. So this is the coronal plane where we calculate the width of the superior cerebellar peduncle. In the sagittal plane, we calculate the width of the middle cerebral peduncle, and in the mid sagittal plane, we calculate the area of the midbrain as well as the pons. And this is the formula that is used to calculate the MR Parkinsonism index, and a value of more than 13.55 indicates an abnormal result and strongly suggests that these patients will go on to develop a classic PSP or progressive supranuclear palsy. So why is the Parkinsonism index so important? It is because it is used in MRI studies to distinguish patients with classic and brainstem variants of PSP from those with other movement disorders. And secondly, it has a greater accuracy than clinical features as well in predicting PSP and increases with the duration of the disease, and thus can be used for monitoring the disease progression as well, and hence a very important index that should be given in all cases of suspected PSP. A version 2 has been added recently for this measurement of Parkinsonism index, which includes average width of the third ventricle on the axial images. So these three measurements are taken, and average of this measurement is V3. And also another important thing is maximal left to right frontal horn width on the axial sections at the anterior posterior commissure plane. We can see this particular measurement that is taken, and these two measurements can also be added and in this particular index to get a accurate index. And it is after adding this particular that is the width of the third ventricle as well as the frontal horns, we can see that a more than 2.5 score is actually suggestive of PSP. So this is a basic reporting format for a case of PSP. So I'm not a very big fan of giving signs in my reports, but in this particular case you have to. That hummingbird and morning glory signs are positive. There is blurring of the bilateral substantia nigra corresponding to probably abnormal category in the spectrum. So there is a spectrum of swallowtail appearances in the movement disorders, which is suggestive of early PSP. And also to be added is a Parkinsonism index in this particular report. So this is the spectrum of Parkinsonism, which includes Parkinson's disease, a classic Parkinson's disease, and Parkinson plus disorders, which include progressive supranuclear palsy, corticobasal degeneration, MSA, and dementia with Lewy bodies, where I have discussed PSP with you, which is the most common Parkinson plus disorder. Now coming to my next case, so here we have a 14-year-old female with generalized headaches for several months, which increased recently with vomiting since the past 2 days, and the symptoms are worsening. There is no rise of the inflammatory markers, no history of malignancy is there. There is no fever, no history of malignancy. Negative history is very important here. I'm scrolling from cranial to caudal direction. You can see ventriculomegaly, some nodular thickenings that are seen in the ventricles as well as in the meninges. And these are the T1 post contrast coronal images where we can see a typical enhancement that is seen, leptomeningeal enhancement, nodular leptomeningeal enhancement that is seen bilaterally. These are the sagittal sections where again we can see typical nodular leptomeningeal enhancement in bilateral cerebral hemispheres, more so along the brainstem and the spinal cord. And there is increased size of the ventricles. So based on these findings, what do you think the diagnosis is? She's a 14-year-old female, pediatric age group with no history of fever, hence ruling out infective etiology. Any history, there is no history of malignancy, hence ruling out metastasis as a possibility. There is no primary tumor that is seen in the cerebral brain parenchyma. So this is the finding, that is widespread meningeal enhancement, particularly around the brainstem with nodularity, nodular enhancement extending to the ventricular surface. The lateral ventricles, third ventricle and fourth ventricle are all dilated with transependymal CSF transudation. So it's a case of diffuse leptomeningeal glioneuronal tumor, which is a rare tumor of the CNS in pediatric age group, and it typically presents with hydrocephalus secondary to prominent leptomeningeal enhancement, often without a readily identifiable parenchymal component. So this is a very interesting case, and it is usually kept as a spotter nowadays frequently in the conferences. So this is another important spotter case that I have encountered during conferences or quizzes. A 25-year-old female with headache and a solid cystic mass lesion in the posterior fossa that is seen. So this is a T2 weighted images where we can see a cystic component and some solid component. These are the flare images where again we can see the cystic component with some edema, surrounding edema. These are the T1 post contrast images axial section where we can see enhancing solid component and the cystic component with peripheral enhancement. And these are the GRE images where we can see some blooming, some foci of calcifications within the lesion. So a lot of DDs are there, but one of the important DDs that we have to remember in this particular case of pediatric brain lesion is, so this was a case of RGNT, that is rosette forming glioneuronal tumor, which is actually a rare, usually midline tumors that involve the fourth ventricle and the aqueduct of Sylvius. And although relatively well circumscribed on MRI and clinically indolent, they often invade the surrounding tissues involving the cerebellum, pons, and even the pineal region. And often cystic component, they tend to have heterogeneous contrast enhancement. They are considered grade 1 of WHO in the current WHO classification of the CNS tumors. The reason I have put this particular tumor in this session is because we have to remember this as a possibility of a posterior fossa tumor in the pediatric age group, and we can give this as a differential in our reports whenever we encounter this presentation. So coming to my next case, which is actually a spotter case. So here we have a 15-year-old female with primary amenorrhea, sensory neural hearing loss, and anosmia. Based on this, what do you think is the diagnosis? MRI brain was ordered to confirm a diagnosis. So these are the coronal T2 weighted images where we can see a particular finding. The olfactory bulbs are missing. There is smoothing of the cortex here in the lower frontal region. You have to always appreciate, you cannot appreciate the findings if you have not seen many cases of normal anatomy of the olfactory bulbs, the olfactory fossa. So this is the normal anatomy of the olfactory bulbs in the olfactory region, where we can see these are the olfactory bulbs which is absent in our case. Along with this, a particular anatomy of the olfactory lobe, where we find a straight gyrus or a gyrus rectus separated from the medial orbital gyrus by olfactory sulcus, which is all absent in this particular case. So Kallmann syndrome is a rare genetic disorder which is characterized by hypogonadotropic hypogonadism associated with anosmia or hyposmia. The MRI is the modality of choice in assessing for the absence of the olfactory bulbs. The coronal T2 weighted sequences are the most effective. The olfactory nerves, bulbs, and the sulci are absent, which is called erheinencephaly. And importantly, the hypothalamus and the pituitary are mostly often morphologically normal in appearance. So coming to another important case, so here we have a patient who is a known case of leukemia who presented with diplopia and left facial palsy, and this is the MRI done for this patient. So particularly if any cranial nerve palsy is present, we get a cis sequence or a fiesta sequence done. These are the T1 post contrast images where we can see there is thickening and enhancement of the nerves bilaterally, that is seen, the cranial nerves, the 7th cranial nerve, 8th cranial nerve, that is seen. So as I have discussed previously in one of the A Day With Me sessions about the cranial nerve imaging, where I had presented a case of Bell's palsy which I had come across. So always it is important to get a post contrast sequence done to look for enhancement of the nerves. So especially if there is multiple cranial nerve involvement, the important differentials to be considered and given are metastasis, which is the most common one, neurofibromatosis 2, lymphoma, leukemia, multiple sclerosis, CIDN, or chronic inflammatory demyelinating polyneuropathy, Lyme disease, and neurosarcoidosis. So these are the important differentials to be considered in case of multiple cranial nerve enhancements and thickening. Uh, so coming to my next case, which is also a case which is related to cranial nerves, and this patient came with trigeminal neuralgia, and a CIS sequence was performed in this particular patient. These are the sagittal images of this patient. So what we can see here is that in this CIS sequence, we can see that the cranial nerve is actually, the fifth cranial nerve is actually being compressed by a particular loop of vessel here. You can see that this particular nerve is being compressed by a loop here, a vascular loop. So this is called a neurovascular conflict. So the finding in this particular case was in heavily weighted T2 weighted sequences, that is CIS or Fiesta sequence. The posterior fossa clearly showed the left superior cerebellar artery indenting the left trigeminal nerve at the inferior surface, because of which this patient was having symptoms of trigeminal neuralgia. So what exactly is a neurovascular conflict? The neurovascular conflict is defined as abnormal contact between the artery or the vein, that is the vessel, and the root entry or exit zone of a cranial nerve. So what exactly is this root entry or exit zone of a cranial nerve? So this is a very important concept that I wanted to discuss in this particular session. That is the root entry or exit zone of a cranial nerve, which is a very important zone which contains a transition zone within it. So root entry or exit zone is a cisternal part of the nerve which is close to the entrance into the pons or exit from the pons, and it represents a transition zone between the peripheral myelin derived from the Schwann cells and the central myelin, which is derived from the oligodendrocytes. So this is a diagrammatic representation of this particular concept. It's a very important concept which was discussed in this particular conference. So while exiting the brainstem, the cranial nerves have a glial segment. This glial segment, that is the root entry zone, which starts from its point of exit till the transition zone, and then there is a peripheral segment. So transition zone is actually a part of the root entry zone. It is not synonymous with the root entry zone. It's actually a part of the root entry zone or exit zone, where we can see that the central myelin is transitioning to the peripheral myelin. So hence schwannomas of the cranial nerves cannot occur before this transition zone. They'll occur only after this transition zone. Secondly, this transition zone is a very sensitive area, is what we have to remember. Within this root entry zone, this transition zone is a very, very sensitive area, and any vascular contact within this area will lead to symptoms. So this is again a diagrammatic representation of the central portion of the cranial nerve, which contains the central myelin, and the peripheral portion, which contains the peripheral myelin by the Schwann cells. And this is the transition zone. So this is a case of neurovascular conflict here within the transition zone. So the transition zone for every cranial nerve is fixed. That is a particular location, the transition from central to peripheral myelin occurs, which is fixed for all the cranial nerves. And we have to remember the transition zone for fifth and the seventh nerve, which is very commonly encountered in clinical practice. For the fifth nerve, it is 4 mm from the root, and the seventh nerve, it is 2 mm from the root. So the transition zone, also called the Obsteiner-Redlich zone, describes a region of a few millimeters where the myelin sheath changes from a central to peripheral type. So the transition zone is susceptible to mechanical irritation and is implicated in neurovascular compression syndromes like trigeminal neuralgia, hemifacial spasm, vestibular paroxysmia, and glossopharyngeal neuralgia. The location of the transition zone relative to the root entry zone for a cranial nerve can be very useful understanding whether a vessel is likely to cause symptoms or not. So what is the pathophysiology behind this particular condition? So neurovascular conflict, whenever it occurs, it can either be a cross compression type or a sandwich compression type. Cross compression is, as we saw in our case, where the compression with a variable angle between the nerve and the vessel is seen. While in sandwich compression, the nerve is entrapped between two different vascular structures, which is relatively rare. So, vascular compression of the root entry zone or exit zone of the nerve causes ultrastructural alteration of the axon, and the altered axons generate ectopic impulses either spontaneously or in response to innocuous external stimuli, and hence become hyperactive dysfunction, leading to trigeminal neuralgia, hemifacial spasm, glossopharyngeal neuralgia. So what exactly happens within this particular area of neurovascular conflict to cause such structural alterations of the axons? So either it can be a demyelination or dysmyelination, it can be a central sensitization or apposition of the demyelinating axons, which cause this particular structural alteration. So in my day-to-day reporting, I encounter a lot of neurovascular conflicts in my CIS sequence or Fiesta sequence, which is not particularly done for a symptomatic patient. But do I have to report all the neurovascular conflicts that I see on my imaging? The answer is no, because it will only confuse the treating physician. The neurovascular contexts are frequent imaging finding in asymptomatic patients as well, and several factors will determine whether the neurovascular conflict may become symptomatic or not. These two important factors are the arteries are more likely to cause symptomatic neurovascular compression syndrome than veins. Why? Because of high pressure and pulsatility, one. Secondly, the anatomic location of the neurovascular complex. That is why the concept of the transition zone is very, very important, has to be remembered in all the cases while reporting a case of cranial nerve anomaly or such patients of trigeminal neuralgia, because the neurovascular conflict at the transition zone is what is very important to lead to symptoms in the patient. So the most commonly involved nerve in a neurovascular conflict is the trigeminal nerve, leading to trigeminal neuralgia, and the vessels that can cause this particular conflict include a superior cerebellar artery, which is the most common one, then ICA, that is anterior inferior cerebellar artery, trigeminal vein, and the superior petrosal vein or the Dandy's vein, which are relatively rare. But all these four vessels have been implicated for trigeminal neuralgia, neurovascular conflict, and very important to be remembered. Superior cerebellar artery, ICA, trigeminal vein, and Dandy's vein or the superior petrosal vein. How to report a neurovascular conflict? So neurovascular conflict can actually, the vessel can be in close proximity to the nerve and not actually in contact with the nerve. Then the vessel can be in contact with the nerve. It can cause compression of the nerve, and it can also cause distortion of the nerve. So these are the four important features of a neurovascular conflict that are to be assessed in any imaging. So in a case of neurovascular conflict, first determine whether a vascular conflict is present or not. Then mention the vessel, whether the artery or the vein is causing the conflict. Then grade the neurovascular conflict accordingly, as I said, whether it is in contact or indenting. Then exact location of the conflict should be measured from the brainstem at the origin of the nerve root. And the location around the root, that is it superior or inferior to the root, and whether there is distal nerve atrophy. This is also a very important factor that has to be mentioned in the report for the physician. That is distal to the neurovascular conflict, whether the nerve diameter has been reduced, whether there is atrophy, because accordingly the patient will be treated with surgical management or conservative management. So coming my next case, which is of a 36 weeks newborn showing flaccidity and diminished reflexes with microcephaly. No evident history of perinatal hypoxia, and this is the MRI picture of this particular newborn, where on T2 weighted images we can see that there is extensive hyperintensity involving the white matter, also seen on the flare images. And these are the DWI images where we can see the restriction in the splenium and the genu of the corpus callosum and the white matter. So it is typically a case of perinatal hypoxia, but it is not a perinatal hypoxia. So what looks like perinatal hypoxia, behaves like perinatal hypoxia, but is not perinatal hypoxia. So this newborn actually died within 1 year of birth. So the findings include a diffuse white matter change involving the subcortical deep white matter, more on the frontal and the occipital regions, profound injury to the whole corpus callosum shows diffusion restriction. There is sparing of the cortical and the deep gray matter, including the basal nuclei. So it's actually a case of a molybdenum cofactor deficiency, which is actually a rare lethal genetic condition caused by a loss of function of molybdenum dependent enzymes manifesting as severe and rapid neurological deterioration. On imaging, it mimics hypoxic ischemic encephalopathy completely. So this is another entity that has to be remembered. So all these are rare entities which I am showing you, but the important thing is these have to be kept in mind along with the common ones that we are reporting on a daily basis. So the next thing that I want to discuss with you, that was discussed in this session very well, and some very important pointers in the reporting of the avascular necrosis of the hip. So the most important initial thing is to diagnose the avascular necrosis and differentiate avascular necrosis from transient osteoporosis of the hip, also called the subchondral insufficiency fracture, and typical osteoarthritis of the hip. That is typically to look for a geographic area of signal alteration with a double line sign, which is very important and is diagnostic for avascular necrosis of the head of the femur. So reporting of AVN. So this is the typical very important reporting format of a case of avascular necrosis of the hip, and all these parameters are to be conveyed within the report to the clinician so that it helps him in the management of the patient. So these parameters include the location of the avascular necrosis, which is the central, median, the lateral pillars. That is a 3-pillar model, which I'll be discussing later on in the video. And this is a very important parameter, that location of the avascular necrosis as to which pillar is involved. Extent of involvement, which is given by modified necrotic index or Kerbaul angle, which determines the risk of collapse of that particular head of the femur. Then the two very important parameters are subchondral fracture and collapse, whether they are present or absent. So any staging of AVN, there are many staging of AVN. The most important thing is, rather than remembering all the stages, is to remember the pre-collapse and the post-collapse stages. So pre-collapse, the management up to subchondral fracture can be done with core decompression. And subchondral fracture has to be reported. Why? Because it needs bed rest and limited movement of the particular limb, because it is very high risk of progressing into collapse. Once collapse sets in, femoral head collapse sets in, the only treatment is hip replacement. Whether there is osteoarthritis present or not, once collapse has set in, the only treatment is hip replacement. Hence, it has to be conveyed to the clinician whether it's a pre-collapse stage or a post-collapse stage. So stage of AVN, typically the modified Ficart and Arlett is followed now, which includes 2A and 2B separate entities, and other miscellaneous findings like joint effusion, marrow edema in the head of the femur also has to be conveyed to the clinician. Dimensions of the avascular necrosis, the area, the subchondral fracture, the collapse segment, everything wherever required has to be mentioned and given, because it will help in the calculation of risk of collapse. Now coming to the important three pillar or segmentation model that determines the location of the avascular necrosis and divides the femoral head into medial, middle or central and lateral pillars. Now the two important reference lines that we have to remember, I'll go systematically here. The first line is drawn from the center of the femoral head to the center of the femoral neck. This is the first line. Second line is perpendicular to it within the femoral head. Now these are the two important lines. Now in the second line, that is within the femoral head, we have to segment it into this lateral, central and medial compartments. As to lateral compartment being 30% of the femoral head, central compartment being 40% and medial compartment being 30% again. Then this entire segmentation has to be divided into anterior and the posterior half by this particular line. So that we know that this is anterior lateral pillar, anterior central pillar, anterior medial pillar or posterior. So this is the particular three pillar model. So any case of avascular necrosis, if it is here, it is involving the lateral pillar, anterior side or posterior side, or whether it is involving both lateral as well as central pillar, it has to be mentioned in the report. Now coming to the modified Kerbaul method or the necrotic index. So here's is when sagittal images are also of use. So I have discussed reporting of avascular necrosis in another video. The link to that video is there again in the description box. So in sagittal image and the coronal image, we calculate the angles and we add them to get a single value, which is if it is more than 200, there is increased risk of collapse of the head of the femur. Now a modified index of necrotic extent was developed by Sherian, where rather than measuring this particular angle at the mid coronal and the mid sagittal plane, he measured it at the area of maximum necrosis, where the maximum necrosis was seen. Secondly, he divided these angles by 180 and multiplied it by 100 to get a percentage value. And accordingly, grades were given. Grade A being small, less than 33%, where the risk of collapse is less, while grade C, that is more than 67%, where the risk of collapse is very high. So this is a typical staging system of Ficart and Arlett, and now 2A and 2B have been developed. But the very important thing, the two very important parameters that has to be assessed more than staging is whether the subchondral fracture is present, whether collapse is present or not. So this is a typical crescent sign, this hypointense, the line that is seen in the subchondral region in these axial images on the STIR and the T2 weighted images. This typically represents a subchondral fracture, and this typically has to be reported in case of avascular necrosis and has to be conveyed to the clinician, because in this case it is very high risk of progressing to collapse. And once collapse is sets in, the only treatment is hip replacement. This patient has to be put into bed rest and has to be treated to manage this, and for that it has to be conveyed to the clinician. Second, this is a set-in collapse where there is loss of the contour of the femoral head that we can see, where the collapse is already set in and the only treatment is total hip replacement. And now this is the reporting format summarized, where the location, extent of involvement, subchondral fracture, collapse, articular cartilage and osteoarthrosis, miscellaneous findings and stage of the AVN has to be given. So this is another case of a patient who presented with pain in the hip, and this is the MRI done for this patient. So what do you see here? So these are the coronal sections and the sagittal sections where we don't see any geographic area of signal alteration. We only see a single hypointense line in the subchondral region, and it typically represents a crescent sign of subchondral insufficiency fracture, which was previously called transient osteoporosis of the hip, and there is no avascular necrosis that is seen in this particular patient. So how do we differentiate subchondral insufficiency fracture and avascular necrosis? Because the managements are different, both the entities. So in subchondral fracture, there is a hypointense band in convex and parallel to the articular surface as we saw, and it is faint and usually immediately beneath the surface with no geographic area. While avascular necrosis, there will be a double line sign with a geographic area of signal alteration. Subchondral fracture is usually unilateral, while avascular necrosis is bilateral 80% of the cases. Subchondral fracture on the post-contrast images, the segment proximal to the band will enhance, while in case of avascular necrosis, the segment proximal to the band will not enhance because it is necrotic. Then coming to another important case of hip pain, where in this case there is area that is seen, but this area on the T2 weighted images, as we see, is completely occupied by small hyperintent cysts, that is subchondral cysts. So there is no double line sign, and this complete area has tiny cysts, that is subchondral cysts. So this represents osteoarthritis of the hip without any avascular necrosis or fracture. So this is another important entity of hip pain that has to be remembered. So all these three entities are to be remembered and differentiated from each other: subchondral insufficiency fracture, avascular necrosis of the hip, and primary osteoarthritis of the hip. So coming to another important topic of discussion, that is soft tissue sarcomas or soft tissue tumors in general. So soft tissue tumors have been given WHO 2020 classification of 5th edition. They have been classified accordingly into adipocytic tumors, which includes lipoma and myxoid liposarcoma; fibroblastic or myofibroblastic tumors, which includes elastofibroma, nodular fasciitis, myositis ossificans, desmoid type fibromatosis; fibrohistiocytic tumor, which includes tenosynovial giant cell tumor. So the entity PVNS has been scraped off. It has been included in the tenosynovial giant cell tumor category. Vascular tumors, which includes intramuscular hemangioma, angiosarcoma; pericytic tumors, that is glomus tumor; smooth muscle tumors, that is leiomyoma, leiomyosarcoma, and so on and so forth. So the key important points to be remembered are PNET, ASKIN, hemangiopericytoma, PVNS, malignant fibrous histiocytoma are all obsolete terminologies now. And mesenchymal chondrosarcoma has been reclassified as a bone tumor. All the soft tissue tumors undergo biopsy except lipoma, elastofibroma, and vascular malformations, and hence this is very important to understand the different classifications of the soft tissue tumors and their appearances on imaging. So this is the appearance of the soft tissue tumors on imaging based on their histologic characteristics. That is, if it is T1 and T2 hypointense or intermediate signal intensity, it is having predominantly fibrous tissue. If it is T1 and T2 hyperintense, it is predominantly having lipoma or fat tissue. Serpentine vessels with fat and hemosiderin phleboliths are all favoring diagnosis of a hemangioma. Infrascapular location, fat and fibrous tissue component is typical of a elastofibroma, which is not to be biopsied. So a relation to a nerve will definitely favor a nerve sheath tumor. Periarticular location with a triple sign is typical of a synovial sarcoma. So all these features of tumors are to be remembered and kept in mind while reporting any case of a soft tissue tumor in musculoskeletal imaging. So what is the role of MRI then? To identify and differentiate venous anomalies, slow flow vascular malformations from high flow vascular malformations, and to decide whether to biopsy or not. To differentiate benign and malignant soft tissue tumors, to provide information on the content of that tumor, whether it is fat, myxoid, predominantly chondroid, or hemorrhagic. To provide information on the surrounding structures as to relation of the tumor with the nerve, the bone involvement. To plan the treatment beforehand and also in the post-treatment assessment of that particular lesion, in the post-treatment changes or residual disease or recurrence. The features in a soft tissue tumor that favor malignant etiology include a large size of the tumor that is typically more than 5 centimeters, a lot of peritumoral edema, necrosis, deep in location with absent fibrosis, and lack of a fat rim. So MRI reporting checklists should include site of the tumor, the location, whether it is superficial or deep, the compartment of the lesion, whether it is single or multiple compartments are involved, the size, the relation to the surrounding structures, the nerve and the bone, the content, the predominant content, which are determined by the signal changes in various sequences, the necrosis, whether it is present, hemorrhage is present or not, the type of enhancement of the tumor, whether it is homogeneous, heterogeneous, peripheral, septal, and finally the diagnosis can be made accordingly. Now coming to a soft tissue tumor which has been described lately with many signs and are being asked quizzes and spotters, that is nodular fasciitis, which is a rapidly spreading non-neoplastic soft tissue lesion that is frequently located in the deep subcutaneous region or in the fascia. The most common location of nodular fasciitis are the volar aspects of the forearm, the lower extremity, the chest and the back, and it typically manifests as a rapidly growing mass. It most often is encountered between 20 to 40 years of age, but children may also be affected. So nodular fasciitis I have encountered during my ultrasound cases, and I have to get a MRI done to actually get to the diagnosis of this particular entity. There are three general subtypes of nodular fasciitis which may be identified on the basis of the lesion, whether it is subcutaneous plane, intramuscular plane or facial plane, and most occurrences of nodular fasciitis are subcutaneous, fascia based and circumscribed. These locations may be amenable to biopsy or excision without any need for imaging evaluation. So this is a facial type of nodular fasciitis seen in a 25-year-old male in the left forearm. So as we can see that this is a very superficial lesion and the patient first presents in ultrasound. So you have to think of this possibility of nodular fasciitis on ultrasound as well. So on this first image we can see that it is a fat suppressed PD sequence where there is a round hyperintense nodule along the fascia with a facial tail sign that we can see. So this is called a facial tail sign, typical for this diagnosis of nodular fasciitis. This is one sign that is seen in the facial type. The other sign that we encountered is that enhancement pattern that is typically seen on these coronal images. This is called a solar halo sign, that peripheral enhancement that is seen on these coronal images. So coming to another case of nodular fasciitis, now in a subcutaneous plane, on the left side of the face, which typically shows an inverted target sign. This is the inverted target sign that is on the fat suppressed T2 weighted images. It shows a mixed signal nodule in the subcutaneous tissue with a high signal at the center of the lesion. As we can see, high signal in the center and the hypointense signal in the periphery, the subcutaneous. And again the facial tail sign that can also be seen. Now this is the intramuscular type of nodular fasciitis, where on the T2 weighted images we can see this particular lesion resembles a cloud, hence called a cloud sign on the T2 weighted images. Now coming to my next case, which is actually an interesting spotter case and it was asked in one of the quizzes, where a 30-year-old female with a history of old brain injury, the gunshot wound, presented with ataxia and gait disturbances now. So it's an old history of brain injury or gunshot wound, and she is presented with ataxia and gait disturbances now. So I'm scrolling from cranial to caudal direction. We can see this gunshot wound here with gliosis which has set in around it, hyperintensity on these flare images of the axial section, and the left cerebellar hemisphere is atrophied, as we can see now. Because of that, this patient is having ataxia and gait disturbances. Now why is this, and why is this history even relevant, and this gliosis even relevant here? So these are the findings, that there is a right parietal encephalomalacia with area of gliosis, subsequently with resultant traction and the exvascodilatation of the lateral ventricle, along with atrophy of the left cerebellar hemispheres with thinning of the left middle cerebral peduncle. So what is the diagnosis here? So it's a case of crossed cerebellar diascasis, which refers to depression in function, metabolism, and perfusion affecting a cerebellar hemisphere occurring as a result of contralateral focal supratentorial lesion, classically an infarct. When affecting the cerebellum, it is well recognized phenomenon following a cerebral infarction, although it can also be because of tumors, intracerebral hemorrhages, encephalitis, radiation necrosis. So we have to keep that in mind. And because of a tumor, if there is contralateral cerebellar atrophy, and the most likely mechanism is thought to be interruption of the corticopontocerebellar white matter tracts, which then result in deafferentation and hypometabolism of the contralateral cerebellar hemisphere. So this is another important case that I found interesting. Now coming to another important session or discussion on rotator cuff tendinopathies and tendon tears. So to discuss that, we first need to understand that the tendon of the rotator cuff consists typically of three important parts. This is the supraspinatus tendon, which is commonly affected in case of rotator cuff injuries, which contains this footprint or enthesis where it is attaching to the greater tubercle, then a critical zone, and then the myotendinous junction, which is commonly affected in trauma. Now, what is the basis for signal changes in case of tendinopathies and tears? So this is the normal signal of a tendon of the supraspinatus tendon, which is hypointense throughout. Now this is because the collagen and the water molecules that form the tendon, that is within the tendon, are tightly packed, and there is no movement of the water molecules to generate any hyperintense signal. Now, when there is disruption of the collagen fibers in case of tendon injuries, there is a hyperintense signal because the water molecules are freely present within that particular area. But the signal intensity is still less than the bursal fluid. Hence, it is called tendinosis and not tendon tear. While in case of tear, the bursal fluid and the signal within the tear is the same. The signal of the bursal fluid and the tear is the same because the collagen fibers are disrupted there and the water molecules are completely free to move. Coming to the classification of rotator cuff tendon injuries, which includes tendinosis and tears. Tears can again be subdivided into partial thickness tear, full thickness tear. Partial thickness tear again has to be classified into articular sided, interstitial, or bursal sided tears. Now coming to the first subtype of partial tear, that is articular surface tear. As we can see that the signal here is similar to the signal at the bursal fluid, so it is actually a tear, but the entire tendon is not disrupted. Only a part of the tendon is disrupted, and that is the tendon which is attaching to the surface of the humerus. So this is the articular sided tear, or also called PASTA, that is partial articular surface tendon avulsion. So this particular tear is present in the articular surface and it is partial. Now if it is present opposite, that is opposite side, but some tendon is actually preserved. So this is the non-articular surface or bursal surface. It's also called antipasta. It's also a partial tear. It's not a full thickness tear because some of the tendon is actually preserved. Now this is a tear which is arthroscopically not visible by the orthopedic surgeon. So it is very important to be reported on MRI images, which is interstitial partial thickness tear, where the articular surface and the bursal surface are normal, but the tear is seen within the substance of the tendon. So this tear has to be reported and has to be seen very well, typically on MRI. Now coming to full thickness tear, which is the topic of our discussion because it needs proper reporting, and all the things that are to be mentioned in the report I'll be talking about because it needs surgical repair, where we can see the complete disruption of the tendon of the supraspinatus. Now what are the things that are to be reported in case of a full thickness tear. The first important thing is the level of retraction. As to the proximal portion of the tendon up to where it is actually retracted from its attachment. So to mention the exact retraction in centimeters from the enthesis, and also mention the level to which the tone tendon is retracted. What do you mean by level? At the humeral head, the glenoid cavity, at the scapular surface, till where the tendon has been retracted is very important. The level as well as exact distance from the enthesis has to be mentioned. Why? Because the surgeon will know exactly how much he has to pull the tendon and how many anchors will be required, and accordingly the cost of the surgery will be determined, because the more the anchors used, the more is the cost of the surgery. The second important thing that has to be mentioned in case of a full thickness tendon tear is the amount of muscle atrophy of the supraspinatus muscle. Is, of course, in chronic tears there is atrophy that is set in, and we have to grade this particular atrophy as to whether it is mild, moderate or severe, because it definitely has an impact on the management of the patient. If the muscle is severely atrophied, then uh, there is no use of doing the tendon repair in such cases. That has to be conveyed to the clinician. So muscle bulk reduction is one thing, and fatty replacement of the muscle is another important entity. Now fatty replacement determines whether rehabilitation with physiotherapy, whether it will be easy or difficult. So if the muscle is atrophied with a lot of fatty infiltration, which is also graded, and if there is a lot of fatty infiltration and less of muscle bulk, it will be very difficult by physiotherapy to actually regain the strength of the muscle. Then another important thing that has to be mentioned in case of tendon tears is the intraosseous cystic changes, whether they are present and where they are present and how big are they, because the anchors that are put within the bone, and if there is a cyst in the bone, then the anchors will not hold and there will be a re-tear post surgery. So massive tears are tears which involve two or more tendons more than 5 centimeters in any dimension, marked muscle atrophy, grade 3 or 4 fatty infiltration, severe retraction and reduced acromioclavicular distance. So some surgeons do not prefer to operate in such cases. So coming to my next important topic of discussion, that is fibroid mapping. So fibroids are the most common benign tumors of the uterus, and very commonly we get requisitions for fibroid mapping on MRI uh, pre-operatively by the obstetricians. So first and foremost, the very important thing that we have to remember is the FIGO classification, which grades as 0, 1, 2, 3, 4, 5, 6, 7 as to what type of fibroid it actually is, and it is universally used. So hence it is a common language for obstetricians as well. So 0 is pedunculated intracavitary fibroid. 1 is less than 50% intramural fibroid. 2 is more than equal to 50% intramural fibroid, which are very, very important and to be mentioned, because these all are symptomatic fibroids and they cause a lot of symptoms to the patient and hence have to be removed, however small they are in size. So the rest include 3, that is 100% intramural, which can also cause symptoms. 4 is 100% intramural with no endometrial contract. 5 is subserosal with more than equal to 50% intramural component. 6 is subserosal and with less than 50% intramural component. 7 is subserosal pedunculated, and 2 to 5 include submucosal, subserosal and more than equal to 50% intramural type. So it is very important on MRI. Very commonly, even on ultrasound, it is not very clear whether this fibroid is in the broad ligament or it is actually a ovarian lesion, which is very much appreciated on MRI images of the pelvis. And a typical reporting format for fibroid mapping is at least 3 to 4 large fibroids are to be given in the report, and the location of the fibroids as to fundal, intramural, with submucosal and subserosal extension, size of that fibroid, the T2 and T1 signal characteristics, whether it is restricting on DWI or not, because early signs of conversion to leiomyosarcoma includes restriction on DWI. Sarcomatous features are to be determined. Figo staging has to be given, and the post-contrast enhancement has to be mentioned within the report in any case of fibroid mapping. So the important interventions that can be planned for uterine fibroid in the radiology department itself include MR guided focused ultrasound surgery and uterine artery embolization. So uterine artery embolization is typically done for vascular fibroids, while focused ultrasound surgery is done for T2 hypointense fibroids showing delayed enhancement and low vascularity, and a maximum of 4 fibroids can be treated with the largest dimension of 10 centimeters. Now coming to my next important topic of discussion, that is LI-RADS. So I'll start this with a question. So a cirrhotic patient with a 5 mm nodule showing non-rim arterial phase hyperenhancement and non-peripheral washout in the delayed phases, what category of LI-RADS does this particular lesion belong to? It's a cirrhotic liver, and there is a 5 mm. It is showing arterial hyperenhancement and washout in the delayed phases. That is typical of a HCC. Now, which LI-RADS category do you give this particular lesion? Typical HCC is LI-RADS 5. So will you give it LI-RADS 5? Now answering this. So to understand LI-RADS, we first need to understand where it is not to be used. So the classification system is meant to be used in livers that have high risk for HCC, that is cirrhotic livers, chronic HBV infection without cirrhosis. But LI-RADS is not meant to be used in less than 18 years old adults, those with cirrhosis due to congenital hepatic fibrosis, and those with cirrhosis due to vascular disorders like Budd-Chiari. So coming to the LI-RADS proper, so what are the major criteria that form LI-RADS? So in LI-RADS, a lesion is called observation. First important criteria is arterial phase hyperenhancement. Second is observation size. The rest 3 major criteria include enhancing capsule, non-peripheral washout, and threshold growth. So what is a typical LR5 or typical hepatocellular carcinoma? So definitely the size criteria should be more than 10 mm to come to a diagnosis of LR5. More than equal to 10 mm has to be the observation size to actually give confidently that this is actually a hepatocellular carcinoma. So that was not the case in our question, which was actually a less than 10 mm lesion. So anyways, it cannot be LR5. Then depending on whether how many criteria it fulfills, it will be given LR3 or 4. So what exactly is included in LR5 or 100% definite hepatocellular carcinoma category? So all the non-enhancing, all the non-rim arterial phase hyper-enhancing observations of 10 to 19 mm with a single major suspicious factor excluding enhancing capsule are included in LR5. Also 10 to 19 mm with 2 or more of the following, that is threshold growth, enhancing capsule, and non-peripheral washout, are included in LR5. More than equal to 20 mm lesions with any one or more of the following, that is threshold growth, enhancing capsule, or non-peripheral washout, are included in LR5. So this observation of 5 mm which showed a non-rim arterial phase hyperenhancement and non-peripheral washout with no enhancing capsule as such comes under LR4 category. So another useful thing that I found in one of the sessions was to differentiate IgG4 related sclerosing cholangitis and primary sclerosing cholangitis. So this is a picture of IgG4 sclerosing cholangitis where the strictures are longer. There are longer strictures, typically involves the distal segments, and the strictures actually show proximal dilatation. There is proximal dilatation of the ducts that is seen. While in case of primary sclerosing cholangitis, there is multifocal short strictures with alternating saccular dilatation and pruned tree appearance. There is narrowing of the ducts peripherally, as we see in primary sclerosing cholangitis. These are the other differences. The age of onset for IgG4 related sclerosing cholangitis is elderly patient, while in case of primary sclerosing cholangitis, it has two peaks in elderly as well as in younger age group. Serum IgG4 level is elevated in case of IgG4 related cholangitis. It is not elevated in PSC. Coexisting disease, there are many IgG4 related coexisting diseases, while in case of primary sclerosing cholangitis, it is inflammatory bowel disease. Imaging of the biliary tree, as I already discussed here, long strictures are seen in PSC, short strictures are seen with beaded appearance. The important thing why we are doing all this is because the treatment for IgG4 related sclerosing cholangitis is steroids, while in case of primary sclerosing cholangitis, it's typically liver transplantation. The clinical course is good in IgG4 related sclerosing cholangitis, while it is progressive in primary sclerosing cholangitis, and hence liver transplantation has to be done.